Hello, you are most welcome, ladies and gentlemen, to your power behind the voice on Tuesday Night Anatomy with Daniel Okwan. Today's meeting, I take you through one clinical correlation which I want you to understand as far as the knee joint is concerned. And my friends, it is something that we call popliteal cyst. One thing that we are aware about the popliteal area is that region where it's of course found, yes, posterior to of course the knee joint. And so what happens that, yes, sometimes there could be some kind of inflammation, something like osteoarthritis actually. Yes, there could be some kind of meniscal tear, okay, which may result in production of excess synovial fluid. Because one thing that we know about the knee joint, yes, is that it is a modified hinge joint. Yes, it is a synovial joint. Therefore, it tells me that, yes, there will be that kind of synovium, okay, which of course will produce that kind of synovial fluid. And so I want you to understand that this kind of cyst which will form is often given an eponym, the Baker's cyst. Now, oftentimes people hear of the Baker's cyst and they think that this kind of cyst is often associated with bakers, yes, that kind of profession. But my friends, it has nothing to do with, yes, anyone who is a baker. But my friends, this baker is actually an eponym, yes, which was actually named after, yes, the first surgeon, yes, who described it, yes, first and foremost. And this guy, yeah, described it around the 19th century. And this person, the full name is actually Dr. William Morant Baker. And so he tells me that that's the same name of the surgeon, so it was named, after him. My friends, at the end of this section, I want you to understand, yes, clinically, whenever the situation is given to you, you should be able to tell whether we are talking about this Baker's cyst, yes, or something else. And so, without wasting my time, let's set the ball rolling, looking at what I have for you today. My friends, so there we are. This is by way of a small description that we're talking about. And so my friends, this is the region of the knee. Yes, by way of orientation, you can see that there's a thigh and therefore there's a femur. And when I go to the leg region, I can see the tibia and of course the fibula. Yes, but the patella is in front over here. So it tells me that there's the anterior aspect. And as I come this way, I'm going toward the popliteal region, the posterior aspect over here. And my friends, one important thing which I want you to understand is that whenever we talk about this Baker's cyst, is by way of some kind of enlargement, okay, occurring in this popliteal area. And how does this enlargement occur? Yes, it's due to some kind of chronic inflammation, yes, taking place in this knee joint that we find over here. And this inflammation could be due to osteoarthritis. Yes, it could also be due to, yes, excessive use of this knee joint, leading to some kind of tear of one of the meniscus, okay, that we find over here. Now, oftentimes this enlargement, which you find it over here, will be that there will be that kind of production, because of the inflammation, there will be that kind of production of excess synovial fluid, and it will get collected in what we call the popliteal bursa that we find over here, okay, forming that kind of cyst over here. And so this cyst oftentimes will be formed, between something we call the medial head of the gastrocnemius muscle. Yes, these things I've done them already. I've explained, yes, these musculature of the leg, of the lower limb actually. And so we are going to see that it will be find itself most of the times, yes, between the medial head of the gastrocnemius muscle and then of course, a portion of what we call the semitendinosus, muscle. And so I want you to understand that. And so when this happens, there will be that kind of swelling, there will be that kind of redness, there will be that kind of pain, which of course we are going to experience, yes, in this area that we find over here. Okay, and so that is what we call this, popliteal, cysts, which you find over here. Now, let's move on and of course give you further description. Now, one thing that oftentimes we appreciate as far as this Baker's cyst is concerned is that if you look at the normal, yes, disposition of the joint cavity that we find over here in the knee area, okay, you can see that it's a bit substantial, but usually because of the inflammation, because of excess fluid, yes, being collected and then trickling down towards the posterior aspect, usually when you take that kind of, x-ray over here, you see that the joint cavity tends to get narrowed. Okay, so I want you to understand that because of course that chronic, so what it means is that there will be that kind of bone to bone, okay, contact, okay, leading to that kind of closeness, okay, over here, because the fluid will be moving all the way and then getting collected mainly in the posterior region, yes, forming that kind of cyst. And so there will be that kind of narrowness, okay, of the joint space that we find in, of course, the knee joint. My friends, so what am I talking about? What I'm talking about is that due to that kind of chronic inflammation, okay, there will be that kind of redness, there will be that kind of, warmth, there will be that kind of pain, which of course due to that swelling, which will get collected in the posterior region. And how is it happening? It is happening for the reason that that kind of chronic inflammation, and so there will be that kind of excess synovial fluid production, and it will get collected to move collected, getting the posterior aspect, okay, and then forming that kind of cyst that we find over here. Now, if you look at this guy that we find over here, there's, of course, I've told you there's a thigh, okay, there's the anterior aspect, there's the posterior aspect, there's the leg, and of course the foot is over here, the ankle is over here. Now, what we see is that if you look at it, oftentimes the pain may get, minimal, okay. That is when you flex, this knee. And what do I mean by flexing the knee? By pulling this one, I've explained the biomechanics over here, okay, by moving, okay, this leg over here, going posteriorly, going towards the back region, so that the stress, okay, the tension, which is, of course, in here, will be minimal, and that one may result in, of course, reduction of the pain. Now, oftentimes, yes, by way of the non-pharmacological therapy to this one, just by way of some kind of ice, that kind of heat compressions, yes, it can minimize it. But of course, through some exercise, or of course, some kind of stretches, yes, you could make this area more, mobile, so that of course one may move with it. If it hasn't become so much enlarged, that is in that case. Now, if it's so painful, then of course sometimes cortisol, yes, may of course be given to this patient, okay, to cause cortisol injection may be given, okay, to minimize that kind of pain, okay, due to that kind of inflammation. Okay, so I want you to understand that. Yes, oftentimes, yes, if it's too enlarged, then of course there may be some kind of some kind of surgical intervention, where of course a needle may be put in here to drain that kind of excess fluid from this kind of popliteal, bursa. Yes, oftentimes whenever we do some of these things, I believe that yes, we should of course give some of these antibiotics to minimize spread of some kind of infection if that one should happen. So my friends, I'm very grateful for your time. Yes, this evening, I believe you find, yes, this meeting also helpful. And of course, you are going to, go on and of course, watch all the subsequent videos that I'll be doing. And so, I'm very grateful for your time this evening. Have a good night, all of you, and may the good Lord richly bless you. Amen.